Medicine, and I am the Community Engagement Director and a certified lactation counselor. I at Reaching Our Sisters Everywhere. Rose would like to thank Georgia Health Policy Center and the Maternal Health Learning and Innovation Policy Center for allowing this safe place for this conversation. Our objective today is to state current recommendations for reducing HIV transmission through breast milk and to identify how to support mothers with HIV who choose to breastfeed. We have 3 panelists today. Dr. Lisa Marie Kramer. Dr. Kramer is a pediatrician assistant professor at Emory Medical School. She graduated from Johns Hopkins Medical School of Medicine and a resident at Seattle Children's Hospital. Her research focused on children's infectious diseases, on tuberculosis detection and prevention among mothers and children affected by HIV. She is working at Grady Memorial Hospital's Infectious Disease Center. Dr. Martina Badell is an Emory OBGYN maternal fetal medicine specialist at Grady as well, and has over 16 years of experience in the medical field. She graduated from the University of Rochester School of Medicine and Dentistry and did her residency at Emory University School of Medicine. And our third panelist is Ms. Valtra Harris. She is a social worker by trade and an IBCLC and has 20 plus years of working with mothers and babies. Valtra's career began as a health educator, and she's teaching parents in prenatal classes in 1997, which led her to teaching breastfeeding classes at Swoop Health Services in Kansas City, Missouri. This led her to the career of lactation. Valtra became the first African-American IBCLC in the state of Missouri. Valtra has been a pioneer in helping and empowering women to breastfeed. Valtra is a mother of 5 and enjoys hiking, cooking, and gardening. So let's get started with this. So with Dr. Kramer.
And then actually Dr. Badell is going to start us off. But again, this is just a conversation with the 3 of us from pediatric representation, obstetric representation, and the lactation counselor. And we've had the fortune of just working together to establish a program to support parents wishing to breastfeed at Grady Memorial Grady Health System. Okay, I'll pass it off to Dr. Badell.
Hi, this is Martina Badell. Thank you so much for having us. And yes, please ask your questions. So we'll just start off with some background, and then we'll go into kind of what we've been working on and doing here at Grady. So, a big push to discuss breast and chest feeding in our HIV positive patients came from patient advocacy groups like the Well Project. This is one of the informational pamphlets they have saying, did you know if a woman living with HIV has a sustained undetectable viral load, the chance of transmitting HIV through breastfeeding is less than 1%. In the US and other high resource countries, guidelines recommend providers support a patient's decision to breastfeed, and this is patient-centered and patient-facing education. Next slide. So global feeding practices for infants born to parents with HIV, and this is pre-ART. So in research risk settings, the recommendation was for exclusive formula feeding, given access to clean water and formula, versus in low and middle income countries, the recommendation, even in the setting of HIV, was for breastfeeding, given reduced infant morbidity and mortality with breastfeeding and lack of access to clean water and infant formula. Next slide. So the rapid evolution of HIV care and treatment. So back in 1981, the New York Times reported mysterious illness, a rare cancer in 41 homosexual males. In 1982, the term AIDS was created. In 1983, HIV was identified as the cause of AIDS. In 1987, AZT was developed in mice and it became the first approved drug for treatment of AIDS. In 1996, the introduction of the protease inhibitors as a combination treatment for antiretrovirals became possible. In 2010, Truvada is shown to reduce the risk of acquisition, or that was the development of PrEP. And in 2018, the majority of patients worldwide were eligible for antiretrovirals and were receiving them. Next slide. So in regards to sexual HIV transmission in the ART era, there's good data now that, once patients are identified as positive and started on treatment, that they can achieve undetectable viral loads within 1 to 6 months of diagnosis. And after 6 months of maintaining an undetectable viral load, there's effectively no risk of transmission to an HIV, to a sexual partner, as long as the person continues treatment and maintains an undetectable viral load. That's commonly described as U equals U, meaning if you're undetectable, you're untransmissible to a sexual partner. Next slide. In the United States, we say, quote, no breastfeeding, but that is no longer realistic. This is a paper from the Journal of International AIDS Society back in 2019, and this was on provider perspectives towards infant feeding among women living with HIV. A national survey of OB, adult ID, and pediatric healthcare providers found that a third reported having patients living with HIV who breastfed despite the recommendation for formula feeding, and hence a call for more research in this field, and to better understand our patients' wishes, and the risks with breastfeeding and pregnancy. Next slide. This is another study from AIDS Patient Care in 2021, looking at increased interest in breastfeeding amongst people living with HIV. And so this was in Germany, where it was not recommended that patients living with HIV breastfed, but it was done. And so they noticed in 2018, there were 13 cases of breastfed infants and 9 the following year. And similarly, sort of just like promoting this idea that patients can self-advocate and may be doing things, and as providers kind of getting a better understanding and being able to support them being important. Next slide. So in 2021, this is a snapshot from the U.S. Department of Health and Human Services guidelines, which every year the perinatal HIV guidelines are updated. And it said, and this is sort of highlighted, that antiretroviral therapy does reduce, but does not eliminate the risk of transmitting HIV through breastfeeding, and therefore breastfeeding is not recommended for women with HIV in the United States. And that had been a long-standing recommendation. But in 2021, there was the acknowledgement that when women with HIV choose to breastfeed, they should be supported in this risk reduction measure to minimize the risk of HIV transmission to their infant. Again, if patients are going to do it, then how can we help them and support them to try to reduce that risk to the lowest possible? Next slide. And then just as of this January, so January 31st, 2023, this same bullet from the perinatal guidelines was updated, and I'll read the highlighted section. So individuals with HIV who are on ART with a sustained undetectable viral load and who choose to breastfeed should be supported in this decision. And additionally, that engaging Child Protective Services or similar agencies is not an appropriate response to infant feeding choices. It does say that replacement feeding with properly prepared formula or pasteurized donor milk from a milk bank eliminates the risk of postnatal HIV transmission to the infant. Next slide. So, the question is really posed, does U equal U for breastfeeding mothers and infants? So we discussed U equals U for sexual transmission, but what about breastfeeding and breastfeeding by mothers on effective treatment for HIV infection in high income settings? I'm going to pass along to Dr. Kramer.
Great. Yeah, if we can go to the next slide, I just wanted to review the data that we have and what we know so far. So before the ART era and the absence of maternal ART, the cumulative risk of transmitting HIV through breastfeeding over 2 years of breastfeeding is about 21 to 27%. So the risk is highest in the first 1 to 2 months of breastfeeding, and that's thought to be because of more enhanced cellularity of the breast milk, and so there's the presence of CD4 cells that are infected with HIV in that early period of breast milk. But then after 3 months or so, it's about 0.6 to 0.9% per month in the absence of ART. We don't have a lot of data in the ART era of when moms are on ART throughout pregnancy. But the largest study that we have to date is the PROMISE trial that was done in many lower and middle income countries, in a multi-center study. And the cumulative risk for transmission through breastfeeding in that study over 2 years was about 1%. Now, one of the big caveats of this study is that the maternal ART for almost all mothers in that study was started 6 to 14 days postpartum. So we really have an absence of data when mothers were suppressed virally throughout pregnancy. But if you look at, the kind of cumulative risk, between 3 and 9 months of age, we would say, a 6-month period of breastfeeding would incur a risk of, 0.4 to 0.5% in that context of starting ART postpartum. Go ahead to the next slide. So this is I compiled the cases of transmission when in the context of when we do have maternal ART that was started during pregnancy. And so this is a compilation of several different studies that I've cited here that you can reference from Botswana, Malawi, Tanzania, and again, some of the in the multi-center trial in the Flynn study. Just looking at the number of transmissions that happened and when that occurred. So of these studies, essentially, if you could advance, there's kind of a summary slide there, that there were 17 transmissions, and all of those transmissions occurred in one of the 3 scenarios: that either mom had a detectable viral load, either the mother reported that there was poor ART adherence, or that the maternal ART started 3 months or less before delivery. So in the context, in the next slide, I'll show you the data that we have in the context of when mothers started ART preconception before that they were pregnant. So we have less numbers from these studies, but overall, have a couple of 100 cases of moms that started ART before pregnancy. And in all of these cases, there are no documented infant transmissions among the babies that were followed for these studies. So that's encouraging news. Again, not enough information because we still need higher numbers to really understand risks of transmission. But in this context of starting ART before pregnancy, there have been no documented transmissions. Next slide. And so in these changing guidelines and in this new era, really the WELL Project has highlighted, and we've experienced ourselves, that support is fundamental, and that this support needs to be multidisciplinary and multifaceted. So not only support from medical providers that include obstetricians and pediatricians, but also through mental health professionals, lactation experts with more intensified supports in the early period, and peers that can share their experiences with breastfeeding, as well as family members to support adherence for mothers. And I really enjoy this quote from one of the moms of, "All I wanted to do was feed my baby. I was not seeking approval. I just needed support." And so we've been, talking through and figuring out how to best establish the support at our program here at Grady. Next slide. And so what we've tried to do is really establish a continuum of care for both the mother and the baby. So ideally preconception, getting moms to start ART as soon as they're diagnosed with HIV and maintaining viral suppression before they become pregnant. And then during pregnancy, for women who choose to breastfeed, we do a prenatal consult with our pediatric ID physicians over at the outpatient PONS clinic, which is our HIV clinic, as well as performing a prenatal lactation consult to prepare for breastfeeding. In the postpartum period, then we do more intensive viral load monitoring of the mothers every 1 to 2 months, really intensive adherence counseling and lactation support through the period. And then for infants, what we are doing is ART prophylaxis of 3 drugs for the first 6 weeks when the period of cellularity is higher for the breast milk, and then lowering that down to just 1 drug for the remainder of the breastfeeding period, continuing for 4 weeks after breastfeeding cessation. We do intensive monitoring for the baby as well for HIV, doing HIV DNA PCRs every 1 to 2 months during the breastfeeding period. And then after breastfeeding cessation, performing testing at 4 weeks, 3 months, and 6 months after cessation. Next slide. I'll pass this to Martina since she does the obstetric part.
Sorry, I forgot to come off mute. So this is just kind of an outline of when we're seeing the patients during their prenatal care. So we see them as scheduled at least once a month in pregnancy. And as far as the infant feeding discussion, we generally discuss it at our initial OB visit with the patients, and then continue to address it at follow-up visits. We have a non-judgmental discussion of options. We review that that infant feeding by formula is the way to eliminate postnatal transmission. However, for women that are fully suppressed and on their medications, that we can support them through breastfeeding. We review the risk and benefits of their specific history, their prior viral loads, if there are any adherence concerns, social support, and mental health. If the patient desires to breastfeed, then we make a formal referral to the PONS clinic to meet with one of the pediatric infectious diseases physicians for a prenatal consult and provide them with the registration materials to be able to do that. Next slide. So as far as counseling, like I said, replacement feeding with formula or donor human milk eliminates the risk of postnatal HIV transmission, and all patients are told this. Patients on ART who are fully suppressed, who choose to breastfeed, we discuss that they should be supported. And one of the things to highlight is, the reasons that people living with HIV may choose to breastfeed, and that's, there are well-documented and known maternal and infant health benefits to breastfeeding. Most people have heard breast is best. And, recently the pediatric societies recommend even up to 2 years of breastfeeding for infant benefit. There are cultural considerations depending on patient's family, and if all their family members breastfed, breastfeeding can be a very important part of infant feeding and family bonding. And additionally, equity consideration. So we know that women of color predominantly are affected by HIV in pregnancy, and also systemic racism, and that patients should have access to potential health benefits like breastfeeding, even in the setting of HIV, to be able to counsel on what are those potential benefits, how do they feel about doing that for themselves and their infant, and just making sure that patients who, like I said, are fully suppressed on their medications, if this is something they'd like to do, that we are equitable and give them the information to make the right decision for themselves and their infant. Next slide.
Okay, so then at the prenatal consults, we again go over the risks and benefits and the current evidence base that we have, and really do an individualized assessment of support needed to exclusively breastfeed. What we do like to do a prenatal lactation consult so that moms can be best prepared before before they deliver, and then we have a breastfeeding agreement that we upload in the chart, and the breastfeeding agreement really just goes over what the risks and benefits could be, make sure that the parent understands, that all the components of the discussion, and we provide a copy for the mother to bring to the labor and delivery unit, so that the providers there also know that the parent has been counseled appropriately. One thing that has kind of come up here is that this is just the agreement is just to make sure that the parent has received appropriate counseling and made an informed choice, but it's not a consent, and so it's not research. I think in the early days of supporting this, there was was a bit of a miscommunication about this being a consent process or research, and that this is just really, this is clinical practice consistent with national guidelines for clinical practice. And so it's just a standard clinical care rather than a research. And this is just a kind of an overview of, how we approach this from the different, providers. And so, mom's been counseled by OB ahead of time. Once, they've gotten the prenatal consults, and once they're admitted to the labor and delivery unit, mom has RNA PCR testing if she hasn't done it already. And we confirm that there's the agreement in the chart. And then when they deliver, the pediatric and mother-baby unit charge nurse is informed about the feeding choice, confirmed that breastfeeding agreement is in the chart, and then a lactation consult is ordered. And then the pediatric providers ensure that the 3 ART medications are prescribed, that the baby has a HIV DNA PCR sent, as well as a complete blood count for monitoring. And the pediatric ID team is consulted just to make sure that they're aware and that they can have continuity of care to ensure that there's outpatient appointment. And then lactation consultants perform kind of standard lactation support, counsel patients on any reasons to temporarily stop breastfeeding, which Valtra will speak to in a minute, and make sure that they have continuity with the lactation as an outpatient. And then one of the other also important components is just making sure that the mom also has her own HIV care during follow-up with an adult provider. Next slide. So a few of the contingencies that we've set up, if we really want to have a prepared parents to be able to breastfeed. And so if they haven't been counseled ahead of time and signed an agreement before delivery, we're not considering them really a candidate for breastfeeding. If a mom meets all of the criteria, but somehow got missed through the cracks, then that would be a situation in which we could do a pediatric ID consult to assess whether that is feasible or not. And then particularly if a mother does not have an undetectable viral load at admission, again, that's not a candidate for breastfeeding. If the mother develops cracked or bleeding nipples, that's a time to stop direct breastfeeding and work with lactation and pediatrics team to have temporary formula supplementation and until the nipples are healed, or if the baby has any health concerns, that they're down too much weight and needs supplementation, we support short-term supplementation. But the idea is that we would aim towards exclusive breastfeeding once that period of supporting the baby's nutritional needs is in helping the mom to transition to exclusive breastfeeding. And then if the baby's in the NICU for any reason, we're doing formula feeding until their term, and mom is able to pump her milk supply until the baby's able to transfer to the well baby unit. Next slide. And so again, I think that first rule is a repeat, but if they haven't been counseled ahead of time, we're really trying to encourage the prenatal consults. And then, if there's concern that the parent still wants to breastfeed and still would breastfeed, then engaging ethics to provide support and make sure that mom understands the risks and benefits so that we can support the lowest transmission risk possible. And so in the outpatient care setting, we do prophylaxis of 3 drugs for 6 weeks. And after that, we support either nevirapine, just once daily prophylaxis until 4 weeks after breastfeeding cessation, or if the baby is having a lot of side effects, the ongoing, the evidence base for ongoing prophylaxis is not very strong. And so kind of making a provider and parent shared decision-making about the need for ongoing prophylaxis. And then we do the maternal and infant viral load monitoring every month. And one thing to note in terms of our guidelines that we're practicing locally is that we are doing the three drugs, and the national guidelines don't actually specify what kind of prophylaxis, whether it would be just 1 drugs and during the entire duration of breastfeeding or not. But we've just chosen to be more conservative because of the lack of evidence, and just also the lack of very absent low rates of side effects for the baby. And so that's been our center's choice, as well as several other centers as well have chosen the same approach. Next slide. And I'll pass it off to Valtra. Doctor, are you there?
Hi, can you guys hear me now?
There we go.
Hi, nice to meet everyone. I'm going to kind of go over today what this looks like clinically, and things that we've experienced, and concerns that people may have or that may come up, and understanding how just being a support and a resource for the mom is important and vital to when you're dealing clinically with this. There were all type of feelings that people have come up with, and I had, as an African American woman, I had my own feelings about ethically and how do I feel, but I also know that everybody should have the opportunity to make their own choice, be their own person, and have autonomy over their body and who they are. So it has been a great learning and educating myself, and in being able to support moms who desire to feed their baby if they're a great candidate. All right, so let's talk about what this actually looks like. So an order should ideally be placed. You should get an order, or the team notifies us of, hey, a mom will be delivering soon, and to be on the lookout for support and help. Instructing moms on hand expression, discussing and reviewing with mom about what to do if you're cracked nipples, if she feels like she's getting mastitis, or even dealing with thrush or yeast in baby's mouth or her breast. Having staff that are knowledgeable about assisting moms with breastfeeding, because we're not there. Your lactation team is not there all the time. And also talking to mom about when to cease lactation if you need to flash feed, if supplementing with formula or donor milk. Those conversations can be hard, but having those conversations respectfully with moms it's a great way for this relationship to go great, and for babies to stay protected and able to breastfeed. Next slide, please. All right, so I kind of brought up situations to consider or to modify breastfeeding. And clinically, we've learned that some things can come up that we might not expect, or I don't know, sometimes just like I dealt with rusty pipe syndrome, where sometimes the milk in the early beginning, when mom's milk is coming in when they first deliver, the breast will have just a little bit of blood in that, and we had to take a pause with hand expression. I talked to Dr. Kramer, and it was not rusty pipe syndrome, so we were fine. But those type of things may come up, and that's why having a team of people is going to make this easier for everyone, so that we can rely on each other and go to the other person if we need to stop or make a judgment call. So that needs to be vital. Like, you can trust each other and be able to have people to go to be able to do this as a group and a team. It's so important. So of course, if we're dealing with any kind of breast infection or bleeding nipples, mom needs to cease breastfeeding, pump. You may have to come up with a plan. This is going to be different for every mom. Some moms, it's one feeding, the nipple just got nicked. Okay, we got a little blood. Or somebody that has an ongoing issue with the way they're latching or positioning infant, or we have a frenulum issue and there's a tongue tie, and baby has to be treated. So all of this is going to be definitely case by case when you're working with moms, as far as your plan. And it's important to kind of tell moms. That's why when Dr. Kramer and Dr. Bedell talks about that prenatal, that counseling beforehand, so they kind of have an idea of what to expect or what may come up. None of this stuff may come out. It may go smoothly, but it's always helpful, and moms are very educated about what to expect. Next slide, please. All right, so these are things that have worked for moms that people have done or used or tried. Having having previously stored milk, like if say the mom was breastfeeding really well, and so the first few weeks she just put milk in the freezer, something comes up, say the baby gets yeast, and like, well, sometimes there have been studies that have shown that sometimes yeast has caused more transmission. There's no concrete, these are just from studies from like the World Health that we've looked at. So those are times where a pause may be good, or using donor breast milk or using previously stored breast milk would be great for mom. Flash heating milk, which you guys can kind of go on the CDC website and kind of go over what that looks like. It does have the ability to kill the HIV virus, and so that's why that's there. Providing donor milk, there are some places in the United States that give their moms who are going to breastfeed, they have a donor milk as a stash before delivery, which that's nice, right? I mean, that's a luxury. That's in California, but those things are great for your team to know, to discuss. I saw someone posed a question about the rusty pipe syndrome. So anytime there is blood in the milk, we're concerned about transmission more so. And so there's going to be a pause just to make sure that baby's safe. So yes, I saw someone's question. So I cannot say for sure, baby is at this amount of risk if we see blood in milk. We don't know, but it's just a precaution if we do see any bleeding for that question. So next slide, please. All right, so we're going to kind of talk about cultural considerations as far as like counseling women and other places. It can be, Dr. Burdell, she touched on this, and especially in other cultures, there is a really, an expectation that you're going to breastfeed your baby, you're going to offer your baby breast milk. And so sometimes this is, and not necessarily, I don't feel like American women, but definitely other cultures where they feel like, oh, why aren't you breastfeeding the baby? Oh, you're not nursing the baby. And so this is something to consider as far as why some women would want to breastfeed their baby and want their status not to be revealed or anyone else to know, because from where they come from, it is important that your baby's being breastfed. So that's just something to remember too, that's another reason why moms want to offer their milk as well as the benefits of breastfeeding. Next slide, please. All right, so let's talk about this. So this presented as far as, especially with me being a woman of color, and African-American women definitely are more affected by HIV at a higher rate in the United States than any other group. And so these are things we have to look at. Like we have to start considering, from both ends. Moms need support to breastfeed their babies to kind of get rid of some of these disproportionate things that we are affected by. But also from the other end, we've had people present where aren't more Black babies going to be exposed to, since you guys have a higher rate of HIV in your community, won't they also be exposed to be more at risk if there's breastfeeding happening with moms with HIV? So once again, this is where, that's your own ethics and that type of thing you have to evaluate. But what we do know is that if a mom wants to be supported, she knows the risk. We, as a team, as a group, we want to do everything so we can get the disparities lower, so that we can start not having this huge disproportion of healthcare in our system. And so support, education is the start of that. So just some consideration when we are looking at women of color, especially because of the diagnosis with HIV. Next slide, please. Okay, so also special considerations. This kind of surprised me. somewhat when I first learned of this, but I guess at one point, people would actually, hospitals, lactation consultants were like told that you would call Department of Family Service if you knew of a woman attempting to breastfeed her baby and she was HIV positive. So that's no longer considered, like, that's not the thing to do. You may have to call your ethics team. You may have to speak with leaders, but calling Department of Family Service is not, it's not supportive. It's not helpful, and it can be very detrimental to a family. And once again, this is a mom's feeding choice. So these are things that we kind of hashed out as a team as how to approach this, because everybody on your staff or your nursing staff or your physician, they might not agree to new policies and guidelines. Like Dr. Kramer said, this is just new clinical standard of care. It's not like, oh, we're giving you permission now, you can do this. This is what's happening. But you just have to kind of talk this stuff out. But what we don't want anyone to not have their infant or be concerned that they're doing something wrong, especially from our standpoint as providers and clinicians and nurses and lactation consultants, and we're supposed to support them. Next slide, please. All right, so we are at the end. These are some resources. I do think there were some questions. I see Dr. Kramer asking them. From my perspective, being clinically working with moms, just having a plan and having a team has made it easier and helped. And I think that if your group is prepared, you all have updated your infant feeding guidelines, you have a protocol, you have like, how are we going to approach this? Who's going to be a point of contact? Sometimes it's just the little things, like who's going to make sure that mom has her follow-up visit, who's responsible for that, who's responsible for uploading the agreement in her chart. Those little things that you work out is going to make this so much easier to do and to support moms. All right, thank you.
Well, thank you. Thank you for presenting, presenters and so forth. If you have any, there's been a lot of chat in the chat, and some of it has been answered. But Joan, we'll go to the question and answer thing if there is any questions in the Q&A.
Actually, Mary, I realized in the format we're using today, it doesn't have a separate Q&A, and so we are gonna turn to the chat where people have entered their questions.
So, would you like to go through some of those, or how do you want to handle?
Yeah.
Is the care planning around breastfeeding for HIV moms included in the plan of safe care developed prior to discharge?
How do you want to handle that, Dr. Bedell?
Sorry, I was answering a different question in the chat. What was the question you just asked?
Is the care planning around breastfeeding and HIV included in the plan of safe care at the time of discharge?
So prior to discharge, the patients have had to have a lactation consult and evaluation while in-house, and we also make sure that they do not leave until they have the infant medication in hand, and that, you know, they've previously signed the agreement. We make sure they already have the infant appointment, the pediatric follow-up within the week. As far as like a written documentation of it, not that I'm aware of. I don't know if Dr. Kramer knows because the baby's discharge is not, is usually done by the pediatricians.
Yeah, and again, that's not me. I'm kind of more the specialist coming in. So I'm not part of the discharge, but that we have a kind of care coordination document that specifies just for nursing as they are discharging patients, just to verify that these components have been addressed, that the baby does have the appointment and that they've been counseled appropriately, and as well as some additional lactation counseling to address any challenges that might come up.
There's another question. Does this information also include trans men with or without HIV on PrEP?
This is targeted to our known positive patients. I think patients on PrEP, we without HIV and on their PrEP, we could individualize, but certainly we wouldn't say those patients can breastfeed. And if their infected partner is undetectable with U equals U, then that the breastfeeding person should not get infected and therefore should be okay to breastfeed. What we could do see is more frequent HIV testing, certainly while breastfeeding.
There's also a question, are there specific support groups or programs to assist mothers or persons living with HIV and their breastfeeding journey?
I think it's a good question. I know that of some of the mothers that I have worked with, I know that they have mentioned that they have some kind of internal groups of support groups, but we don't have any current support groups. But that is something that we've discussed as would be a very helpful adjunctive to our program.
Yeah, a number of our patients have sort of self-volunteered that if other patients are interested, they'd be happy to talk with them and help support them.
Great. What are the side effects of antiviral medications offered to infants receiving breast milk from HIV positive parents?
It's similar to this. You mean specifically from the breast milk or specifically from the prophylaxis that the babies get directly?
The question is about the side effects of antiviral medications on babies.
Yeah. So I mean, the common side effects that we look for are, any kind of anemia, a neutropenia. Sometimes there can be a rash. And one of the mothers that we had, the baby did develop a rash, and so we stopped the prophylaxis. But for the most part, it's fairly rare. And also fairly routine. So any of the high-risk babies who are born to moms with higher viral loads are also on triple prophylaxis. So this is routine care that we provide all the time. So it's not really that different. It's just that it'd be providing 3 drugs to a low-risk baby during the breastfeeding period. And again, we just do the 3 drugs for the first 6 weeks, and then we go to mono prophylaxis with the nevirapine, which is a once daily only.
Another question is there guaranteed access vis-a-vis payment, insurance to lactation consultation in your community? Yeah, so
Medicaid is, the lactation consultant group that we've been working with, Breastfeed Atlanta, does accept Medicaid. And I don't know, Valtra, if you have any other comments on that, but.
So yeah, this is important to know, and I probably would prenatally have the mom, like you guys check and follow up with that. It's only come up for us once, and we were able to resolve it. The mom, for some reason, there was some discussion about a hefty copay and her not being able to pay for that. And so we had to be a support and reach out and speak to them. But I would definitely just kind of try to smooth that out beforehand so it doesn't come up. But that's a great question, because it may, because it's come up once for us.
And also going back to where they're doing the study, Grady Lactation can also set up visits as well. So.
And I think I can't underestimate or understate, the importance of strong lactation support. And I think, it's just so important and crucial at that early time period that the moms actually get in physically to see lactation specialists if they haven't, during the hospitalization. So that's come up with most of my patients have needed some extra support, and having that easily accessible is really critical. So for people in other states and other settings that are looking to establish these programs, I think that's a really important component of that.
There is a question in regards to the training. What training are your IBCLCs, RNs, and institutions receiving to support those living with HIV?
So this was a very interesting point. I kind of, after I started working with Dr. Kramer, I just kind of started taking classes online with there's the just like a HIV Institute in DC and also in San Francisco where you can do online training. There are hospitals. I know there's a local hospital here in Atlanta. They are sending their whole entire team before they roll or do anything out to an informal training. But I would suggest you do that. If I would try to get as much education, go through as many seminars or a class on your own or as a group. Of course, if your hospital will support it, that would be great. And you all can do it as a team, but it will be essential to learn. And I think we are learning as it's happening, right? Because I've had a few phone calls with the CDC and we have gone back and forth with like, oh, well, wait, you're right. Maybe that's, I didn't think about this, or, oh, I forgot about when somebody has a tongue tie. So some of these things, if you can, get ahead of it, yes, it's great to do.
I think also we've learned that a lot of healthcare providers and staff like touch a patient through the labor and delivery and postpartum period. And so kind of as much education as we can. And in clinic, there's MAs, the nurses, the lactation support. And when patients, come in where we are, it's a teaching institution. So there's the residents. So we've tried to, in a number of different forums, like make sure that the OBGYNs are aware of the new guidelines and how we're implementing it. Then we've met with the nursing leadership and the nurses, and we've done a town hall, and just then also being on the floor and saying, because forever ago, it was patients living with HIV cannot and should not breastfeed. So it's definitely a major shift. And for people to sort of get on board, they really have to understand why it's changed and who it's changed for and who it hasn't changed for. And so I think, we've learned that education and as much outreach and education to anyone that might be interfacing with these patients is really important.
Yeah, and then, working with the team, Valtra and the nursing team had suggested, developing computer-based learning for everybody that's required. And I think that's going to be a great intervention. So that's currently in development through our team. So I think having universal education, that's really kind of a required part of, the different healthcare providers training is really critical. And then I've seen a couple questions about like bleeding nipples or the rusty pipe syndrome. So in those situations, when you do have, direct blood from the breast milk, it would just be temporarily stopping breastfeeding and using formula during the time until it's resolved, and then restarting breastfeeding. So mom can pump during that period, and then and not use that milk for the baby.
And there's one in here about should ID physicians be primarily responsible for approving breastfeeding for HIV positive persons, since pediatricians do not track the mother's labs?
So I think the ID, I think, is that maybe a pediatric ID physician? These patients should have their own ID physician or OB who is comfortable managing HIV. And I think we work to try to align like mom and baby visits. But even if that's not feasible, you know, the lab order, whoever is managing the maternal HIV is who would generally order the maternal viral loads in the postpartum period, not the pediatrician. I think if you have a setup like ours where the women and children's clinic kind of lives in the same place, which is lovely, then it's more straightforward. But even if they didn't, I think the patient's provider should know that she's choosing to breastfeed and that the agreement does involve these viral loads, and to be followed by her provider, along with the baby being followed by the pediatrician.
Yeah, and I think that question has come up of whether, you know, we've had any challenges with insurance covering the extra testing. We haven't had that so far, and I hope that that will not arise, but so far we haven't. And so, yeah, just keeping in close contact with the maternal provider. Sometimes for pragmatic reasons, I just end up ordering the mom's viral load on the days that, you know, she's seeing us. But it's just really more pragmatic. And I think a close communication with the adult provider for the mom is really important.
Is there any other community outreach in reference to getting the word out? I know working with other agencies, WIC and other federal agencies, and their guidelines are not at this point right now. We haven't received any information down to respond to this. So have you reached out to those agencies to see about change? Even though it says CDC, we still follow different guidelines until that comes out. So have any of you reached out or?
I have not reached out, but I do think that is probably a vital and important thing to do as this is new and to navigate that, because really it is your community that's probably going to be a big support and vital, especially I feel like in the African American community. So maybe Mary, that's something we could talk about with Rose and collaborate, because it has not been done. Not as my knowledge anyway.
Does anyone else have any questions or any questions dear to your heart that you think that needs to be answered at this point in time?
Hi, this is Jane. I was just going to ask about mixed feedings and how you would counsel these patients who are interested in breastfeeding with a low viral load. You encourage them, I'm sure, to exclusively breastfeed, but when somebody mentioned, nipple breakdown or blood in the breast milk, that you discontinue it until that resolves. That can happen a lot during the initial couple of weeks. And what is the alternative you give there? Do you offer patients donor milk, or do you move to formula then? And what does that mean for the mixed feedings? My understanding was that it always put them at higher risk for HIV transference. So what would you counsel on that?
Yeah, so just to clarify, the data on mixed feeding and increasing the risk of transmission of HIV from mother to baby is in the context without maternal ART. So we really don't have a lot of data on transmission when moms are on ART. So in that context, we encourage exclusive breastfeeding, and really that's the goal. But for short-term periods where the mom's milk is just coming in, or if she's having some of these complications, we say say it's okay to have a short-term mixed feeding, but that it's not a good long-term plan. So if mom's not able to get to the exclusive breastfeeding point, you know, and is planning or wanting to do mixed feeding long-term, that would be a contraindication. So, so we're supporting moms to truly try to get them to exclusive breastfeeding. And also to, at the same time, because there's lack of data, there's no data to really say that short-term mixed feeding is a problem. And so trying to decrease that stress on mom as well, because I think that is definitely a source of stress for the mothers in that period if they can't give their baby breast milk. Donor milk is a great potential option. It's just not very available. So we've worked a bit with the Donor Milk Bank of Florida, and they have varying supplies. And when they have extra supply, they're very, able to, give that to patients. Most of the time they have these starter packs that are a lower cost, but ongoing, provision of donor, milk supply is just very expensive and cost prohibitive for most people. So they have, wanted to work with philanthropic societies to kind of support more cost-effective measures, but it's not a consistently available.
Thank you.
Well, thank you for the panelists, and thank you all for joining us. There will be, I guess at this time, we'll put in the link for the evaluations.
Actually, we will be emailing it to you.
Okay, so all the, you will get a link for the evaluations. But we thank you all for participating, and thank you for the panelists for your information and agreeing to do this after I twisted your arms.
Thank you, everyone.
Thank you.
Pleasure. Thanks for having us.
Thank you.